the SMCI. This is the SMCI lunch lecture. I'm Katie Brown-Johnson with the Evaluation Sciences Unit, Senior Qualitative Researcher. And I am so excited today to host Dr. Lewis, Dr. Eldrin Lewis. First, we're going to do some announcements. Selena, I think, will be putting information about CME credit in the chat. So if you need CME credit, please follow up there. Our big SMCI event that's happening this week is the Lean Conference. That is tomorrow and Thursday. I'm very much looking forward to it. I will be there. And the announcement for the Lean Conference at Stanford is that even if you have not registered, there's available on-site registration, both for both days and for single day registration. Lisa, is there anything else to add in terms of Lean?
Perfectly.
Okay, great. Any other announcements before I get started? And thank you. I see some folks turning your videos on. If you can, that's great to encourage engagement. And if not, we get it. You're also hopefully taking care of your bodies and eating lunch at the same time. All right, I'm so pleased to introduce Dr. Eldrin Lewis. Dr. Lewis is the Simon H. Stertzer MD Professor of Medicine and Chief of Cardiovascular Medicine at Stanford School of Medicine. And over the past 4.5 years, he's really expanded the clinical reach of the division to both the East Bay and the South Bay, expanded faculty to 105, increased the diversity and inclusion of faculty and trainees, and expanded the clinical research and clinical trial capability to make sure it's intersecting with existing basic and translational research. I can't say enough good things about Dr. Lewis. He is really interested in preventing the development and progression of heart failure, looking for novel strategies and therapies for treating heart failure and comorbid illnesses that are risk factors. He performs quality of life research as well to make sure that we better understand how to improve outcomes and include them in medical decision making. You know, in his own practice as an advanced heart disease specialist, he specializes in the management of patients with advanced heart failure, heart transplantation, and those with mechanical circulatory support devices. He's got about 250 publications and is leading an effort to understand how to enhance, the diversity of participants in clinical trials. And that's actually how I ran into Dr. Lewis, was with the Diverse American Heart Association grant. Last but not least, he holds numerous leadership positions. He's the chair of the Scientific Publishing Committee for the American Heart Association, president of the AHA Board of Directors for the Western States, and chair of the Research Committee for the Association of Black Cardiologists. He's here today to talk to us about care and quality improvement approaches in heart failure. I'm just so pleased to have him and welcome him to our SMCI lecture series. So, Dr. Lewis, I will hand it over to you.
Thank you so much, Dr. Brown-Johnson. I really appreciate your just really kind and generous introduction. My goal is to try to live up to that introduction, but I'm really excited to have an opportunity to talk with you. I'm just going to switch the display a little bit. I think you can see the slides now.
That's great. Yes.
Excellent. And I'm really excited to have an opportunity to talk with you today about care and quality improvement approaches in heart failure. It's near and dear to my heart because I think that we all have an opportunity to make a difference. And So these are my disclosures. I don't think it'll impact the talk, but in full disclosure, these are my funding sources. So heart failure has really come a long way. It affects over 6 million people in the United States. And fortunately, since 1986, there have been increased options for management. And survival and quality of life have improved dramatically, but management has really become more complex, and it's the reason that we have this subspecialty. And in fact, this is an illustration that shows the impact of ACE inhibitors initially, and then adding angiotensin receptor blockers, beta blockers, the combination, and then adding mineralocorticoid receptor antagonist, and then ARNIs, the angiotensin receptor and neprilysin inhibition, not to include the SGLT2 inhibitors. So with this, we've collectively seen over a 60% risk reduction in the overall mortality of patients. And in fact, if you look at drugs approved for heart failure by indication, a lot of them are driven by mortality and morbidity. I've jokingly said that we're a victim of our own success. So unlike some disciplines where improving quality of life will give you an indication, that's really hard to get an FDA approval, and also hard to get third-party payers to pay for it. But it's really important. Hospitalization reduction makes sense, hemodynamic or physical function. But once again, for quality of life and symptoms, we have very few therapies that have been approved based upon those outcomes. And in fact, where are we going? We're going to precision medicine with a better understanding of basic science and mechanisms, the implementation of genetics and outcomes, as well as care delivery and gene editing, acute illness management, not to mention transplant, which is a staple for what we do, percutaneous and surgical valve replacement and targeted treatments, including those for hypertrophic cardiomyopathy and TTR amyloid, basically gets us to where we are today with the contemporary management of heart failure. But with that comes cost. So we know that the cost has increased in healthcare in the United States from $2.7 trillion in 2011 up to over $4 trillion each year right now. And in fact, if you look at the drivers of this, is hospital care, physician services, even though we're often at the excuse for why it's so expensive, you could see that physician services and provider services represent a relatively small portion of the pie. And this is according to the American Medical Association. And in fact, there are many drivers of increased healthcare costs, including the aging population, the cost of medications, hospitalizations and skilled nursing facilities, as well as rehab, the rising prevalence of social determinants of health. And that's something that we could do a better job of, but this is increasing the comorbidities in the management devices and procedures, as well as critical care management and the imbalance between prevention versus treatment, as well as changing lifestyles. So we know that it cost over almost $2 billion for the approval of a single drug because of all the failures along the way. There's a lack of tort reform in the orphan drugs that kind of keep these expensive meds on patent for longer, where we don't have the generic drugs driving down the price. The decentralized and extended family is kind of requiring people to be admitted to skilled nursing facilities instead of going home with family. And this is going to continue to be a problem, and the limited social support that we see because families are spread out. I still remember when I was a kid, almost all of my family lived in Mississippi. So if you needed reciprocity and help, you could rely on family, and that's something that we can't really see as often. But coverage for prevention, we're not seeing it. We're also seeing more money spent on end-of-life acute illness care. But once you get out of that acute illness model, there's not nearly as much money spent on how to manage patients as they approach the end stages of their disease. So they end up coming back to the hospital. And then finally, obesity, diabetes, and sedentary states that basically lead to increased morbidity. So these are the stages of heart failure, stages A, B, C, and D. A are at risk, B have structural disease but never have been symptomatic. Stage C are the majority of the patients that I manage with chronic heart failure across the spectrum. And then stage D are these advanced stages of heart disease, of heart failure. And I would say that we need to really focus our efforts on primary prevention because it gets really expensive as patients kind of progress. And I would focus on preservation of quality of life by identifying patients at risk or who have structural abnormalities but are asymptomatic and preventing them from ever developing heart failure in the first place. But as we have increasing therapies, we have the 4 pillars, as I mentioned before, and also all of the other therapies we have, there truly is a disparities cliff. So right now we're doing studies looking at gene therapy and editing genes to cure heart failure. But that probably will come at a price tag of north of $1 million for that therapy. That's going to be a problem. And what we'll see is the disparities that already exist will just be exacerbated, and we'll see people falling off of that cliff in management. So what are the things that we can do? Well, these are a lot of things that are all areas for improvement of care and care delivery, but I'm going to highlight just a few, just because of time, including inpatient care and 30-day readmissions, improving symptoms and quality of life, health equity and racial differences, and also cost. So prevention is for all of us. And even though I'm a heart failure transplant cardiologist, anytime I have an opportunity to catch someone early on, I say my job is to prevent you from ever needing my services. And so we need to work on primordial prevention, so preventing the risk factors. So weight loss, exercise, avoidance of toxins like alcohol, substance use disorders, other drugs, and early identification of genetic polymorphisms that lead to disease, dietary changes, and screening. Primary prevention would be all of the things we do for primordial, but also controlling the blood pressure, sugar, reducing proteinuria, protection during cancer treatments, behavioral changes, and all the components of primordial prevention. And then secondary are post-MI care, stage B cardiomyopathy treatment, the treatment of peripheral arterial disease and CKD, and all of the other components. And for optimization of heart failure, it really takes a village. It's a team effort. We should establish etiology, including catheterizations, what's reversible, what are the labs that we should check, achieve euvolemia, and get people to a dry state. That's going to prevent remodeling. And so sometimes a right heart cath, in-terminal pro-BNP, this is where technology can come into play. Stabilizing comorbid conditions, hypertension, COPD, kidney disease, and CAD, as well as establishing GDMT, guideline-directed medical therapy. And the goal ultimately is to restore functional capacity and get them back to where they were possibly before their heart failure. We may need cardiopulmonary exercise testing. But as I said before, it is a team effort. And there's a big team that's involved, including the primary care provider, the cardiologists and cardiology providers, nurses, nurse practitioners, educators, physical therapists, surgeons, nutritionists, psychiatrists, and therapists to deal with the 40% of people who have depression and anxiety, and chaplains, and all of us work together to try to optimize. The 30-day readmission is a bit tricky issue, right? Because we have the Medicare penalties, 4% of our total Medicare budget for a year could be at risk. And I actually think of it very similar to the project management triangle. 30-day readmissions, length of stay, and mortality is similar to speed, cost, and quality. You know, basically you can get 2 of 3, right? You can get something done fast at a comparable cost, but the quality is going to be down. It could be fast with high quality, but the cost is going to be high. And it can be low cost and high quality, but it's going to go slowly. So the goal is to get all 3. That's pretty difficult. So what we've seen is as we reduce length of stay, which is something that we have to do, with longer length of stay, you have lower 30-day readmissions and lower mortality. If you have a shorter length of stay and a lower 30-day readmission, you have a higher mortality. And this created a lot of angst among people because we saw that trend upwards post-discharge. And if you have a shorter length of stay and lower mortality, your 30-day readmission rates are going to be higher. So as we try to come up with quality metrics, we have to really think about what are the ones that matter? What are the ones that we should do, and how do we influence it? And then also implement it into a healthcare system without breaking the bank. The other thing we have to kind of really look at is the disparities in how patients are treated. So this is a study we did using the Premier Registry, and it was adults with primary diagnosis of heart failure admitted to ICU, 571 hospitals, 104,000 patients. And one of the things that we found was in hospitals that had cardiology available, unfortunately, if you were, so race was a predictor of being cared for by a cardiologist in the ICU. And so Black patients were less likely to get care by a cardiologist. And then if you look at other factors in the multivariable model, the overall risk is regardless of age, sex, and whether it's rural or urban setting. So that's something that we have to really see. We know that Black patients with heart failure tend to be diagnosed at a younger age. They have more severe disease. And this was a study that we did called TopCat, where we looked at Black and non-Black patients and looked at spironolactone versus placebo. And patients who were Black, they had a self-described Black patients had a higher probability of the primary outcome. But if you look at the impact of spironolactone versus placebo, whether or not you were self-classified as Black or non-Black, you saw a benefit of the spironolactone, and it had a similar effects. There were no differences in adherence to study medications. The reason this was important is because a lot of reasons that we don't have diversity in clinical trials is investigators sometimes believe that increasing diversity will decrease the quality of the study. That is not the case. We also saw that 51% of 51% higher risk of heart failure hospitalizations despite favorable characteristics among patients who were self-described Black. Overall mortality was the same. This was a difficult study to do, and I looked at this and I saw this among my own patients when I was at Brigham. And so we ended up looking at the characteristics of patients admitted with a primary diagnosis of heart failure from the emergency department, and we did multivariable modeling and propensity matching. And what we found was that patients who were self-described as Black or were of Hispanic ethnicity were much more likely to be admitted to the, or less likely to be admitted to cardiology, more likely to be admitted to the hospital medicine service. And I am not disparaging hospitalists. They do a tremendous job. The problem is the access to the care delivery, the nurses, the education, the disease management, and getting prior authorization for medications. And so what we found is that in this multivariable model, once again, Black race or Hispanic ethnicity, older age, female gender, as also all were predictors of less likely in a multivariable model, less likely being admitted to cardiology service. And then also if you have comorbidities as well. And whether or not it happened in 2011 to 2013 or 2014 to 2017, there was no change. The reason we did this is I first identified this problem back in 2007, and I was looking for interventions. I brought attention to the department, and despite this, without having strategies, nothing really changed. And the reason it's a problem is because the 30-day readmission rates were driven by service. The probability of being readmitted was not driven by race, but driven by where you were admitted to the service. And when we did propensity matching, we also could see that the odds ratio of cardiology admissions was less for Black patients as well as Hispanic patients and females. This was an observational study that looked at 46 hospitals in Maryland, showing once again that patients who were Black or Hispanic were much more likely to be admitted to observation status. This creates a problem, and part of it is because, once again, access to service, care delivery, and disease modification is probably going to be, these all are going to be less likely to be implemented if you're in an OB status. But also the out-of-pocket cost can be a problem as well, which we'll get into in a minute. So a few years ago, we put together a piece where we looked at pathways between kind of structural racism or institutional biases and disparities in heart failure, including unequal access to healthcare, implicit and explicit bias, substandard facilities, delay or avoiding seeking care due to medical mistrust, and the lack of workforce diversity, unequal employment, which also can make it challenging, state-sanctioned violence, but then also residential segregation, which often will cluster patients who have a cluster of social determinants of health to lack of access to high-quality education, toxic exposures, maladaptive behaviors, and targeting of health-harming substances, as well as food deserts, all leading to these healthcare disparities and heart failure. And the last thing has nothing to do with race, but has a lot to do with cost, the financial toxicity of heart failure management. For providers, this is a problem because we have limited care options. We spend a lot of our time discussing the cost versus benefit for these drugs that are super expensive for out-of-pocket costs. There's frustration and burnout, as well as extra administrative burdens and costs, as well as explaining how many times do we have to explain the rationale for the out-of-pocket cost. But for patients, it can be a choice between food versus therapy. If I have a therapy that costs $800 and I'm barely making ends meet, I have to make that decision. And sometimes even ration follow-up care because you can't afford the copay, and decisions not to seek care because you can't take time off from work. The impact on chronic stress, the out-of-pocket cost, less prevention of progression of disease, and this grows inequities and disparities. The other thing that's really frustrating for me is when people delay their care, because that delay can be the difference between life and death and the difference in morbidities as well. This was a nice study done looking at medical expenditure panel survey, which asked patients specifically about foregoing care. And it turns out that 60% of non-elderly and 46% of elderly patients with heart failure reported deferring care due to financial barriers. And if you look at those who deferred care, their out-of-pocket costs were $8,000 more per year than those who didn't defer care. So trying to put a cap on the out-of-pocket costs could be a strategy that can help reduce the disparities. And then we should provide patient-centered care. And what is that? That's healthcare that establishes a partnership among practitioners, patients, and their families to ensure that decisions respect the patient's wants, needs, and preferences, and that patients have the education and support they need to make those decisions. So an example that I often will use is when I was a resident, had no money at all. I took my car to get inspected when I was in Boston, and they said I needed a tie rod end. And I said, okay, fine. It doesn't pass inspection. How much does it cost? Well, it costs $450. I'm like, okay, no, I'm just going to drive somewhere else and get somebody else to inspect the car and try to get it. I said, what is that purpose? And when the mechanic explained that as I was driving down I-95, without that tie rod in, the wheel can just fall off your car when you're driving 70 miles an hour, I said, okay, I'll make that investment. Thank you very much for educating me. But we need time to provide that patient-centered care. And that includes building patient-physician relationships, establishing language barriers, breaking down those language barriers, addressing disability and patient experiences, having the patient participate, addressing cultural competency and how that influences expectations, and then also the personality of the patient, and establishing realistic goals of care. So as I kind of finish, I want to focus on solutions. What can we all do in taking care of patients? Well, the first thing we could do is use case-based strategies for policy changes. You can imagine, for any of you who've gone to Washington and have advocated to change things, you know how complicated it is. And I often find that if you have a patient as an example and a family as an example, it can actually illustrate something that can actually change practice. An example that I would give before this example is dialysis. There was a person who was near and dear to a congressperson, and no one could afford dialysis, which was not covered by Medicare. And that actually became a therapy that was offered by Medicare. Now, some people, economists, will debate the impact on CMS of that, but it was a patient who actually couldn't survive and was going to die because they had advanced kidney disease, to actually change CMS policy on covering dialysis as a therapy. So this is an example a long time ago of one of my patients, a 28-year-old with dystrophin cardiomyopathy, had muscular dystrophy, was multiple admissions, and eventually was in cardiogenic shock on a balloon pump. We could not get this person off. We were going to have end-of-life care and withdrawal care, because they were not a candidate for heart transplant and they needed a destination left ventricular assist device. The problem was this person had Medicaid, so Mass Health, and Medicaid did not cover destination VADs. I called, I went through, denied. And so the mother was completely distraught. And I kind of said, well, you know, Ted Kennedy is one of our senators. You should actually reach out to Ted Kennedy and actually go through this and start there. She did that. Ted Kennedy got involved, and then this person ended up getting DT-VAD accepted. And in fact, coverage for destination therapy, LVAD, ended up being covered despite patients being on Medicaid. But despite that, this is a recent study by Karen Maddox, who's one of my former colleagues, and she basically looked at Medicaid expansion after quote-unquote Obamacare, looking at healthcare costs and utilization projects. The only states that are included were the ones that had complete data from 2012 to 2015, so well after Mass Health had already approved VADs. And what they found is even after you've expanded it so that it covers VADs, there was no impact on utilization. It moved the needle by less than 1%. And in fact, if you look at predictors, you know, females were less likely than males to get a VAD. Black patients, Hispanic patients, as well as other races compared to whites, but also Medicare and Medicaid much less likely than privately insured patients, and certainly the uninsured weren't getting VADs. And then if you look at zip code, if you look at the lowest quartile versus the highest, the top 3 quartiles, you can see that there's about a 30% less likely odds of getting an LVAD. And when you look at mortality rates across race, insurance status, zip code, and gender, gender was the only one where you look at the adjusted mortality rate and adjusted odds ratio of being discharged home, with females less likely than males, but everything else, the outcomes were exactly the same. We need to do better. I think technology is the second thing where we can move forward. We have 18 million deaths due to cardiovascular disease. We know that the management is becoming increasingly more complex. So quality improvement initiatives should be focused on AI-assisted and tech-assisted diagnostics, behavior modification, medical record integration and care delivery, wearable technologies, and implantable devices. And in fact, if you look at the increasing investments, we're seeing the investments. And there are opportunities to reduce inefficiencies, improve access, reduce cost, increase quality, and truly personalize medicine, especially as we get more genomic data into our clinical practice. But the challenges are the productivity paradox, right? The privacy of this, the impact of errors, and appropriate endpoints, as well as the regulatory requirements. So we need to focus on numerical endpoints, including precision, accuracy, validity, and true technology development. But the secret sauce is how do we use technology to improve meaningful outcomes to patients. Patient-reported outcomes are critical. And I know that about a year and a half ago, you got a lecture from Dr. Sandhu, Alex Sandhu, on quality of life, and that's why I toned down some of the quality of life data. But this is a model that we put together some time ago that linked biological and physiologic variables to overall quality of life. But all of these things are validated health status measures, and they're patient-centric. And these are things that we can actually measure in clinical practice. And this will enable us to actually improve the overall outcomes of patients. We should think about, for the patient's perspective, what are the kind of rates of change, right? For patient one, if you have an acute event and then you rapidly recover and you sustain, that's what we want for quality of life. But if you have a second patient who basically has a decrement in their quality of life, it takes a long time to recover and it doesn't sustain. The question is, when we're looking at interventions, is this where we should put our interventions? We don't really have enough data right now to better understand these predictors. The other thing we need to do is to consider the integrative models of care over time. And we know that there are varying patient needs for technology, whether you start at the beginning of the diagnosis where you may be more survival sensitive towards the end stage of heart failure where you're more symptom sensitive, and focusing on hospice and also after death, the bereavement for the family. This is where, once again, it takes a village, where you may have focus on the usual care team in the beginning, but as patients approach end of life, the palliative care teams are going to be important, and those are going to be important measures. But for implementing patient-reported outcomes, there are a lot of challenges and solutions, including identifying what the true patient needs are, the patient engagement, having provider engagement, and having actionable tasks in our electronic health records. What's terrible is when we have data that's dumped to us and we don't have the approach, there's nothing that we can do to change that measure. We need to have an adequate roadmap, robust efficacy data, have true health system integrations from the beginning, and look at novel endpoints, as well as having frameworks for reimbursement for different models. I'm still frustrated with the fact that I always say that as a heart failure and transplant cardiologist, I'm like the toothbrush in Walmart, that I'm the loss leader. You come in for $1 toothbrush, but you come out with a television, a high definition television or a grill. And that's the same thing with health system. We spend too little on E&M work, but that's what really can move the needle. So we need to come up with a different framework and have patient-facing actionable items. What do I mean by that? Instead of us having to measure PRO and then we call the patient and say, you need to do A, B, and C, have the patient be armed with how to implement changes using that technology. And then finally, our pathway to the future with novel technologies is, once again, consider social determinants of health, health equity, health literacy, culture, trust, numeracy, as well as baseline status and locus of control, have both provider and patient care engagement and the caregiver engagement to assess technology, to implement it, and then to identify the stakeholder prioritization. What are the endpoints? What are the EHR changes that really move the needle? And all of these components of these stakeholders play a role. And that will allow us to have optimal results, to have actionable data for patient-provider facing interface. And so as I summarize, in cardiovascular medicine, and I appreciate Katie's comment that we've expanded our faculty from 72 to 105 to meet some of the needs. But this is an integrated system, including cardiothoracic surgery, vascular surgery, Cardiovascular Institute, and the Stanford Cardiovascular Network. We know that we have demographic factors that are changing here in the Bay Area. And we're seeing an aging population, and we're also seeing increase in unemployment rate. And that's going to change how we provide care and the access. We also know that there are environmental factors influencing strategic decisions, including payment reform. And if we're not careful in academic medicine, we're going to miss an opportunity, because increasingly you're seeing plans like Walmart and Target basically getting into the healthcare business. And so we need to create partnerships so that we can meet patients where they are. So there are 4 strategic imperatives. That includes translating Stanford science into clinical care, building an integrated value-focused network, leveraging digital to unlock new access, and optimizing the Palo Alto hub for inpatient care. For translating science into clinical care, it's important that we generate increased awareness among regional care providers and patients. When I first came here almost 5 years ago, the perception of Stanford is that we take care of rich people. That cannot be our long-term perception. We should take care of everyone. But in order to do that, we have to have something that elevates what we do that is uniquely Stanford, and then show that this can be an attractive place as a destination center for care. This includes an integrated value-focused network. That includes going out to Emeryville, Redwood City, 2585, as we've done, and the UHA clinics, but also creating a cardiovascular hub outside at Valley Care and strengthening the community physician alliances between UMP and faculty, establishing cardiovascular quality metrics, and then once again, integrating care pathways across primary and secondary care. And it's going to be critical that it's the right patient at the right place at the right time. What I mean by that is, if I were building a transportation system, I am not going to try to have a jumbo jet fly from SFO to San Jose's airport. That's not cost effective. You would probably say we need buses, we need trains. And similarly, we should have if a patient doesn't need tertiary and quaternary care, they hopefully can be taken care of in the community with our help so they can get the same care. Third is to leverage digital technology to unlock new access, and this includes a digital front door, having e-consults, encouraging proactive patient use of My Health that can help with education. One of the things that I really want to do is have videotapes of our own providers doing education to patients that you can give to them as homework, so that you don't have to spend that time in clinic teaching them about strategies for weight loss, smoking cessation, the importance of adherence to medication, and then using digital technology. And then finally, we need to have patient flow. It truly, I've said this is the third time I'm saying it takes a village to take care of these patients, and the entire infrastructure at 800P is critical, and we can work on how we can optimize improvements over time. So in conclusion, technology will expand more rapidly than the system can integrate. The technology is there. We need to understand how to implement it and how to make it patient-facing. Patient-reported outcomes can change behavior and adaptations. Last example I'll give you as an anecdote, no one needed other outcome data for PDE5 inhibitors or medicines like sildenafil to be uptaken. People would pay out of pocket because it improved their quality of life. They didn't need anything else other than that. But why is it hard for us to get patients to take an antihypertensive to lower their systolic blood pressure, to prevent that erectile dysfunction, to prevent stroke, heart attacks, heart failure, kidney disease? We have to have case-based policy changes, and that can be effective one-on-one, and then addressing disparities in access to improve overall outcomes. And finally, Stanford should absolutely be at the center of all of these solutions and the center of improvement of quality. Thank you very much.
Thank you so much, Dr. Lewis. If you're available and can come off for, yeah, just to say thank you.
Thank you.
Yeah, so much to chew on. Please, I would invite you to put questions in the chat or to come off mute and ask questions. There's so many different directions that I could go in terms of questions. Dr. Lewis, I'm super curious about the quality of life piece and your thoughts about, you know, how to provide, like, what data we're going to need. I'm very interested in the cardiology service as one of the mechanisms for access and bias really in care, and I'm curious about how Stanford is doing that. I'm sure people are going to be interested in hearing more about case-based strategies. I was actually just at a long COVID hearing for Santa Clara County that was similar to this, where a constituent had reached out to the public health departments and alerted them that there was interest. And within a month, they had pulled together international experts. But I think my big question is, like, with all of the cornucopia of work that needs to be done, what's the one place that you would ask this group to take a look at? Where's the starting point? And then we'll hear from you next, Dr. Lindquist.
Absolutely. So thank you so much, Dr. Brown Johnson. I think the starting point for this group is to let us know as cardiologists, as specialists, how we can be a part of the solution. Because you don't have many cardiologists who are in quality care and kind of outcomes and improvement space. We traditionally have been trained as an acute illness model. So patients have an acute stroke, an acute heart attack, cardiac arrest, and then we are ready. We have very expensive technology. We can put them on ECMO. We can do CPR. We can do rapid cooling. And then we give them back to the primary care doctor and say, we saved their lives. But in reality, there are many cardiovascular conditions that are chronic conditions, and we need to have a chronic illness model. Probably the first 10 years of my career was focused on trying to change the mindset as a cardiologist, because we were focused on, well, we can fix this, but we don't deal with kind of family meetings. We don't deal with this. So letting us know how we can be helpful. I think in terms of quality of life, I think implementing quality of life into medical decision-making is paramount. There were a lot of barriers which I didn't go over, but the reason it's important is it can actually motivate patients to adhere to medications. So I see this in my practice, that when I can show them that your quality of life has improved. We started an SGLT2 inhibitor. You didn't like it. You have $200 copay per month. You know, eventually they'll be generic. But I remember a patient last week where they actually said, I actually do feel better. And I showed them their improvement. They said, I just want to thank you. I can do things that I couldn't do before. And now I said, okay, well, I'm greedy. And I actually use these words. I'm a greedy doctor. I want to get you even better. So now I'm going to add, we're going to up titrate this and we're going to do this. So now they're buying in because they can see something other than death, because death is final. We need to kind of really focus on quality of life. And then for cardiovascular services, really thinking about how we can integrate primary care, psychologist, the basic and translational scientists all into care delivery, and really, once again, meeting patients where they are. That's why it was so important to go out to San Jose. We're going out in November to meet directly with primary care doctors, because that's a desert. And there's no excuse in California for there to be a desert of cardiologists as close to San Francisco as San Jose. But there is, because cardiologists are kind of, they have a choice, and they'll say, I'd rather live, I'd rather live in San Francisco than living in Gilroy. There are only 3 cardiologists in all of Gilroy, but the comorbidities in Gilroy are through the roof. So we have a new faculty member who's from there. And I'll stop with this anecdote. I hinted that I grew up in Mississippi. I remember I used to run a program where I would recruit people who wanted to go into medical school and they came to Harvard and they learned, they had a summer research experience similar to what we do here at Stanford. And I would always pick 5 of the 15 would come from Mississippi or people at Mississippi schools, because I wanted to give back to Mississippi. And some of them had never left the state of Mississippi, surprisingly. And the one thing that really got me to pause was somebody who, after I gave a lecture, said, Dr. Lewis, I said, yes, in a shy voice, why aren't you coming back home? And I'm like, and I tried to stay professional, but I kind of said, what it would take for me to be able to make things the way I want it in Mississippi is much beyond what I could do unless I was the Secretary of Health and Human Services for the state of Mississippi, with a lot of support from the politicians.
Thank you so much. We've got 2 hands raised, and I'll also invite you to put comments in the chat. Dr. Lindquist, your question.
Thanks, Katie. So, Dr. Lewis, I'll synthesize or condense my immediate reaction to one word: wow. But I'll expand that by simply saying that I applaud your ability to couple together your passion as well as the rigor that you have obviously developed in the evidence that you provided us. My question really pivots off your last comments: is how do we, as Stanford, who are a collection of content experts, how do we address this problem of deserts in California and across the country? Because we all know that not only outcomes, but actual optimum therapy is closely tied to the availability of expert consultations and the development of a team. I would reflect on an earlier presentation in this series from Brian Brady, who is in the nephrology group here at Stanford, about how Stanford has been able to leverage the ability of experts using a team to partner with primary care in the delivery of patients and management of chronic kidney disease. I'd really want to compliment you in thinking about ways in which we can restructure the system of care of people, particularly those in the safety net. And I'll follow up with an email to you, but congratulations for a moving and very thorough review of a complex problem.
Thank you so much, Dr. Lindquist. And I am looking forward to, after this, having an opportunity to meet with multiple of you, including you, Dr. Lindquist. And I would say there are 3 key areas where we can actually make a difference. I think the first is to leverage our content expertise, but also the reputation of Stanford to actually change national dialogue around these areas. And so the example I would give is my presidency of the board for the Western states. So 13 states, including California, and I just started July 1st. The reason I was excited to be in this role is it allows us to actually scale to a higher level, and then use an organization like the AHA to partner with Stanford to then address some of these issues. The second is to bring awareness. And so there was a recent publication that showed that 47% of the counties in the United States don't have a single cardiologist. So if you live in one of those, that means half of the counties in the United States, if you have an acute MI, if you have a cardiac arrest out of hospital, if you have a stroke, the probability of your survival goes down dramatically. So bringing attention, the Washington Post reached out to me and interviewed me, and I went through the appropriate communications needs, and one of my patients who lives 3 hours away actually was interviewed as well. So that's the example of using a case-based example of how difficult it is for this patient to actually drive 3 hours to see me. I tried to use that opportunity to talk about CMS. Many of you probably know that effective January 1st of 2025, CMS will stop covering video visits or telemedicine. That's their plan. I really wanted the Washington Post to highlight that, because if I live 4 hours away and I work at McDonald's, I can't afford to drive 8 hours round trip to see a doctor. If telemedicine is now no longer available, then the healthcare quality is going to go down. They didn't put that in the story, but I was hoping they did, so that politicians will get pressure from their constituents to basically say, we have to block this, and then we have to still have access. So those are examples of how we do it. And then the third thing that I plan to do is my goal, and I have the perfect fellow who's going to become an attending, hopefully, fingers crossed, after she finishes her fellowship. She's really interested in working with safety net patients patients who are in the safety net units. The problem is our insurance won't cover it. So what I want to do is to cover the percent effort for her so that she could go out and work in a safety net hospital, one clinic 1 day a week where we're paying for her salary, and then she'll be able to provide Stanford quality care to patients who otherwise can't do it. 20% of a salary is not a lot of money. The impact on that patient care delivery is phenomenal. And if we can do this here, then we can go out to all of the academic medical centers and say, why can't you do it? Why can't you cull out just a small amount of salary support so that it's not volunteerism, but it's actually having high quality, highly educated people providing that care?
Thank you so much, Dr. Lewis. Lee, I see you're up next, and we'll see, Shu-Chen, if we have enough time for your question, you might put it in the chat as well. Go ahead, Lee.
Just a quick one. Again, Dr. Lewis, this was fantastic. As a former heart failure ICU nurse working on the East Coast with Dr. Bergen, this was bringing up a lot of really great memories. I had a question. You mentioned bringing physicians to the table, to the quality table, but we have a very siloed sort of lots of professional boundaries, a little bit of protectionism. What is your advice for actually doing that, getting them to the table? Because of course we're all more powerful in teams than we are on our own. So I just wondered if you could speak to that briefly. And again, thank you for all that you do.
Absolutely. Thank you so much. And I'll make it quick so I can answer as many questions as possible. What I'm going to say is the first thing is to get organizations to communicate together and to do joint projects to tackle these problems, because we're siloed in care delivery and we're also siloed in our organizations. We need to do a better job there. And I think we work around a common theme and then basically build out. I think that's one. The second is that we have to take the expectations off the primary care provider, because it's hard for me to be able to do all of the care delivery management of GDMT for heart failure. But 85% of heart failure patients are managed primarily by primary care. We need to give them the tools through technology, and then build out the e-consult program, and then say, this is how you manage. I think integrating PharmD into care delivery so that the PharmD basically works across specialties, so that it's not just heart failure specific, cardiology specific, but they can actually be embedded within a primary care practice as well, so that they're the ones who will help up-titrate the guideline-directed medical therapy.
Thank you so much. Shu-Chen, would you like to chime in?
Yeah, and Dr. Lewis, and thanks so much. I think I put it in chat, but I can also ask. I really like the idea you're talking about. We're not just reacting on patient-report outcomes, but we all know that behavior change is hard. Just can you explain more your idea of like generating patient-facing actionable insight and what we can do?
Absolutely. So I'll give an example, then I'll give an anecdote and then an example. The anecdote is, if we were to ask firefighters to respond to every smoke detector that went off in every house in their jurisdiction, it would be a problem. It would be inefficient. But that's basically what the healthcare system is asked to do. So what I would propose is that you have a clearly actionable item, and it actually, if it's technology, for instance, it will tell the patient, you should call your provider. Your weight has changed by 3 pounds. Your voice has gotten hoarser. Your quality of life, it seems like your exercise capacity has diminished. This might be significant. We suggest you call your primary care doctor. You call your cardiologist. So that's one example. Another example would be having algorithms that are carefully curated that will say, okay, here's your rescue plan. So I'm on a stable dose of diuretic. If my weight goes up by 2 pounds, it automatically through Bluetooth integrates with my phone, and it says, your weight has gone up by 3 pounds over 2 days. Have you eaten anything? Have you eaten out? No. How do you feel? Fine. We suggest you have an extra dose of diuretic and check your weight tomorrow. And then tomorrow it automatically will say your weight still hasn't changed, call your provider. So now we have some basic guidance for patients. That's an example. And then the last one is where it pings us, like all of the patient messages. Imagine if you had AI and the ones where we need to actually make a decision, it automatically pings our phone, through Epic and says, this is a situation. The actionable item is, should they get labs? Should they do this? And the computer using AI automatically sends that, so that's an actionable item saying, yes, they should, or no, they don't need labs. Their creatinine is fine.
Thank you so much. As we do a round of applause, I'm just gonna voice a couple of the comments that are in the comments for our recording. It just looks like there's a note about team-based and a role for advanced care providers, nurse practitioners, and PAs in managing some of the patients, in addition to the PharmD co-management concept. So it sounds like there's some work that's been done at Stanford around that. And then just lots of thank yous. Again, thank you, Dr. Lewis. Thank you all for being here. I hope to see all of you at Lean tomorrow and Thursday. And we will see you next time with the SMCI lecture. So thank you all so much. Any last words, Dr. Lewis?
I just wanted to say thank you. And if there's anything that we can do, let us know. We have a tremendous number of faculty who are really interested in quality improvement. And I would love to build, when we talk about team science, having team science around quality improvement initiatives that can be scalable to other institutions would be great. And that way we can call it the Stanford way, the Stanford solution, and it actually brings attention to us, but it also allows us to really move the needle as opposed to just saying it can't be done. Thank you.
Thank you. Thank you so much. All right, everybody, take care. And thanks so much for joining us today.
Thank you.